Okay, I'm H.S. Kim. My co-operator is Dr. J.Q. Han, Dr. Ji-Hoon Kang, and Dr. Yang-Soo Kun, Hyo-Soo Kim, Kim Taeun 과장, and anesthesiologist Yeon-Jung Cho professor. Okay, let me introduce my case. Slide, please. Okay. 84 years old male complaining of dyspnea, severe yes in echo. Coronary angiography showed two vessel disease, including left main, plus hypertension and previous chest operation history and COPD, plus medication. Target is aortic stenosis and two vessel disease, include left main, plus surgical risk is intermediate, plus cardiomegaly, diffuse lung infiltration, ECG is normal, plus water motion is good, ejection fraction 61%, plus therapy area 0.9, mean gradient 44, peak pressure, peak velocity 4.3, plus coronary angiography taken 2 weeks ago showed segmental lesion from left main distal part to proximal AD. FFR was 65%. Proximal RC, we have also segmental and focal lesion. FFR was 78%, plus aortoilofemoral artery looks with a normal range in TAVI cohort, plus renal artery aortic arch is good, plus valve calcification is severe, especially in NC and RC, plus but annulus LVOT is calcium-free. The size is about 23.5 or 24, very similar with annulus and LVOT. Plus, is once again the sinus and ST junction. Sinus is spacious, 31 on the left one, 28 in the right. NC is 30. ST junction size is 26, bigger than annulus and LVOT. Plus, coronary height is more than 15 millimeters. ST junction height 19 millimeters. Good. Plus, annulus to membrane septum length is about 7 millimeters, longer than average, less chance of AV block after TAVI. Plus, first angle, 3 cusp view, elaeocranial 24-12, cusp of left view, elaeocaudal 4-12. Plus, this is summary of measurement. Plus, when we choose Sapien 3 Ultra, it is ambiguous. 23 millimeter undersizing, 26 oversize. We have to do 2 or 3 overfill or underfill. Plus, when you choose Average Pro 29 with ideal oversize index 22%. Plus, when you choose Accurate Neo 2 25, the oversize index once again ideal 19%. When you see the upper size matrix, 25 nominal valve, actual diameter is 28. 25 nominal diameter means the waist diameter, while actual diameter is 3 millimeter bigger than nominal diameter. Thus, we calculate 28 millimeter actual diameter, leading to 19% oversizing, very similar to Avalute. Plus, there are 2 issues: valve type selection, how to obtain commissural alignment, because he requires coronary intervention and coronary accessibility is important. Plus, I always consider 9 clinical conditions to choose TAVI valve among 3. There are 5 risks of leakage, AV block, coronary obstruction, tear, and dissection. All these risks are not associated with this patient, not horizontal heart. The only factor in this patient is future coronary accessibility that favors sapient or accurate neo2. Considering longevity of valve, orifice area of valve thrombosis tendency is very important. In this regard, accurate neo is preferred. Thus, to summarize the valve type selection, oversize index optimization prefers Avalid Pro accurate neo. Necessity of coronary intervention prefers accurate neo. Plus, second issue is how to obtain commissural alignment for the future coronary accessibility. Left is well aligned commissure. Post is far away from the both coronary ostia. Plus, drawbacks of valve alignment is difficult coronary access, difficult redo TAVI, and poor hemodynamics. Thus, we have to obtain commissural alignment. Plus, accurate neo is a very representative valve type to make commissural alignment by ourselves. There are 3 steps. First step is insertion with the safety bottom at 6 o'clock. And I advance whole system through aortic arch into annulus level on the 3 cusp view. Usually we can see the open cell that emerges from the right side of silhouette. Then we have to rotate clockwise to make open cells appears at both sides, right and left. If it is overturned excessively, open cell appears on the left side. Then you have to reverse turn, counterclockwise. After getting open cell at both right and left side, third step is you have to confirm the cusp overlap view. You have to get open cell on the right side. Then you start deployment process. Plus, once again, in cusp overlap view, why open cell appears on the right side? When you see the cusp overlap view, right and left cusps overlap. Thus, open cell should appear on the right side, while the left 2 open cells are merged into silhouette of valve frame. Thus, after deployment, you can check the alignment. On the 3 cusp view, you can see 3 posts evenly distributed. Center post is backward. On the cusp overlap view, you can see 1 post on the right side that is located in commissure between right and left. And the remaining 2 posts are overlapped on the left side. So we can confirm the commissural alignment in this system like this. Plus, here is size dimension of accurate neo. Nominal diameter is waist diameter, in this case 25 millimeter. Actual diameter is 28 at the lower crown range. Landing zone is 7 millimeter among 14 millimeter perivalvular seal that is composed of porcine pericardium. Plus, thus, to summarize, 84 years old male with CVAS with coronary lesion. Plan is TAVI plus PCI using accurate neo 225 millimeter valve under commissural alignment and coronary intervention.
Okay, Dr. Kim, I think this case is a very interesting case. So anyhow, before the TAVI, you have to fix the coronary region with a stent, right?
TAVI and PCI.
Okay.
Because
we
I'd
need.
like to
We will have a
demonstrate
discussion
how
about with the
easy
panelists
to
in your cases.
PCI after accurate implantation.
Good morning, Dr. Kim. As usual, it's a very, very educational workup with all of your cases. Very insightful, also the balanced view of the three valves that we have. The question that I'm having, looking at the sequence, when you have a aortic stenosis and coronary heart disease, are you planning in general, to do the coronary intervention before or after in different sessions, or if you do it in one session, you're doing TAVI first and then coronary, or coronary and then TAVI? What's your thought?
Yeah, there are three situations: PCI first, stepwise, or simultaneous PCI and TAVI, and TAVI first, then PCI simultaneously or stepwise. For conditions, usually we perform PCI before TAVI in certain regions. Usually the patient's workup is well done to delineate a coronary lesion that was known as significant. We perform PCI first, followed by TAVI in stepwise in a separate session. But the lesion was not definite, because at the TAVI situation, we perform coronary angiography. If it is significant, we perform PCI and TAVI simultaneously. In this case, lesion was looks not so severe, but for live demonstration, we performed coronary angiography 2 weeks ago, and we found physiologically significant. Thus, usual conditions, we perform PCI at that time, and 2 weeks later, we perform TAVI on live. But I'd like to demonstrate the situation. TAVI first, then PCI at the simultaneous session.
Okay.
Because in SAPIEN or ACUNEO, we can do TAVI followed by PCI. And SAPIEN, it is no problem to do a commissural alignment because it's short. But in ACUNEO, when we perform ACUNEO, we can learn how to obtain commissural alignment. That is the educational theme for this case.
Okay. What about the valve selection? Actually, this is a good case for the accurate neo. Any comment?
Okay, Floro.
Okay.
So,
what
while
about
discussion,
Dr.
I'd
Stein
like
or
to-
Dr. Dabugati, regarding to the valve selection? Would you comment about?
Floro 바꿔달라니.
Thank you. Professor Kim went
Right,
over
absolutely.
excellent way of looking at all three different valves. But here, in my opinion, that I would do TAVI first, and because the coronaries are borderline, in my opinion. And which valve? We only in the United States do not have the accurate neo, so the discussion is mainly between Portico or Evolute and Edwards. So I would have just gone with Edwards here, in my opinion. I think 23 plus 2 cc would actually be very good. And the sinuses are large. I don't think even with the Medtronic Evolute Pro there would be any problem with the accessing or with the coronary obstruction. So, but access later on may be difficult with the self-expandable valves.
All right, sequence, the PCI first, TAVI first issue for particular these patients, I think a little bit, if you see the FFR is 0.6 something, is very tight stenosis, remain and proximity, and very much a calcific lesion is not a simple, PCI cases. So personally, I think is old ages, right coronary artery 0.7877, it's just running sometimes. However, main and LAD, personally, I think a fixed first is a really tough region, and then whatever you select, TAVI procedure in the next.
Yes. Okay.
Finkelstein. Okay. Please comment.
Well, I think, hi, Dr. Park. As always, I have to decide what are you better, a lecturer or an operator. But regarding the question, I think that we're getting into an era of what we call a patient-tailored therapy. So there cannot be one rule for all patients, okay? I think that in this patient, and this is from a long experience, dealing with left main in a patient with truly severe aortic stenosis, when you're taking care of the left main, all of them for a while crashes.
Sure.
So in this case, I would have done
Facing
PCI to the RCA, then I'd do the TAVR, and then I would have bring him back electively, if needed,
Patient.
to the left main LED.
Facing off.
But again, that's
Very
my
good.
opinion, just seeing this, as we said, patient-tailored therapy.
Dr. In, any comment?
I just wonder if you use acroneal first, and if the patient needs TAVR in TAVR, is that an issue regarding the future coronary axis? Because you will deflect the valve, it's a very high valve. So maybe in the future there will be coronary issue there.
Okay, Dr. Kim, okay, go ahead.
We
your
performed the
procedure.
pre-ballooning just 1 millimeter less than the annulus. That is prerequisite in accurate nail. Because of the weak expansile force, so we have to do pre-ballooning.
In your cases, the area of the calcium is more than 1,000. Did you have any plan for the cerebral protection for the sentinel
No.
for these cases?
No,
Okay.
it is not available. Okay, best angle.
His
6 o'clock. Just maintaining the safety button at 6 o'clock. I'd like to advance whole system.
during the procedure, could you show us the hemodynamics on the simultaneously?
헤모다이나믹 보여주라네. Okay, you can see the
We did
open
not.
cell on the left
We
side.
do not need the hand operation in the on screening.
And I have to do
Okay,
the
good.
counterclockwise rotation. And wait for some minutes.
Is the three-cusp view or the
Three-cusp
overlap view?
Always. Do you see the disappearance of open cell on the left side, the appearance of open cell on the right side? Do you recognize?
Yep.
Okay. A little bit deeper. Test it. 안 보인다. 좀 더. 25? 25? Okay. 자, 저장하고. cusp of left view.
So it's a top-down
You
deployment.
can see the open cell on the right side. The commissure is well aligned. Three cusp. 자, 신에 다이 쏘고. Okay, alignment is good and the level is also good.
Any other
A little bit
comments
deeper.
about the position of the
Okay, 자,
accurate nail?
now I would like to deploy it. The first step is upper crown. Release very gently. Plus deploy, 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 deploy. Can you see?
Yes. Please go ahead.
Okay, now the upper crown is on.
Test it. Then I push the system.
Right.
It is a little bit high. Then we release stabilization arch. Release. 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 release, release. 끝까지.
Other out.
오케이, 저장하고. I think the level is a little bit high because of heavy calcium chunk. The
I agree.
crown cannot be lowered furthermore. Just sit down once again.
I think we have to be careful. When you
조금
final
넘기지.
release of it, there is a chance of the pop up.
So if you see the shaft is on the left side biased. That means I push enough force. Yeah. Then after rapid pacing, I try to deploy whole system. Pin off. And 160, pacing on. Pacing on. Rapid release. off. 저장하고요. 자, 그럼 뺄게요. 넣고. Release is a little bit cumbersome because we have to avoid the touch between the system and valve. So please withdraw the wire, then the system will be centralized. Okay, wires advance.
Okay, good.
It's also important that you keep the wire down, because if you lose the wire, the left ventricle, then it's going to be very difficult to advance
Okay, capture.
the arches. And
Okay, stop. Wire stay. Then I separate the pigtail that is captured outside of the valve. 프레시 프로파일 보여주나? 응. 이야. 뭐라고?
So far, the deployment of the accurate neo is the excellent. These are some very interesting cases.
This is a three-cuspid view. So we can see the evenly distributed post and stabilization arch. That means alignment is good.
In the hemodynamics, okay.
좀 빼고 centralize 할게요. Here I just do a root arthrography to check the depth of the valve. Okay, that's it. It's good. No regurgitation. Okay, ariocaudal and ariocrinial sweeping.
We
I
cannot
always
clearly
check
see
the
lower
valve
margin of
deformity.
the annulus because the aortogram was
자, sweeping.
formed in the too far from the density of the contrast is not so enough.
As you can see, always under aerial view, AP diameter is always shorter because of eccentric round shape, not round, the ovoid shape of annulus. How about post ballooning?
Before the post balloon, could you show us the RAO view, extreme RAO view, more than 50 because in the radial
We'll
force
show
of
you the post-ballooning effect under ariocaudal view, cusp of left view. To expand the valve frame, and that is once again recoil. That looks like just weak, but that is very kind of physiologic to accommodate the pulsatile movement of annulus. And anyway, for the interest, I will show you the post-ballooning procedure. 1 millimeter bigger than previous ballooning, exactly same as average diameter. 23.5.
Dr. Kim, before the post-ballooning, would you mind showing us the TE?
Okay, T 보여주고. During preparation of post-ballooning, we can show you the T finding. Previous angio 보여주고.
can clearly see the TE image.
Can you show? Yeah.
It's a very
Section.
educational and very informative. Is there any a little bit the paravalvular leakage in the at 12 o'clock in the TE image? In the long axis,
Just 1 o'clock.
1 and
12 o'clock?
1 to the 2
조금
o'clock.
더 아까 NGO에서는 안 보였는데.
Actually, the angiogram was done in the too high, far from the valve, so we cannot
Okay.
clearly see the
NGO once again, minus. Here is NGO. Undiscernible leakage. Okay, anyway, we can show you the effect of post-ballooning. Ariocaudal, cusp of left view. Here we can see once again the well alignment, cusp of left view. We can see the one post on the right and two overlapped posts on the left. It's well aligned. So in the future, in the next coronary intervention is not should not be difficult.
what size of the balloon?
23.5, 23? 23 for the safety. So pacing on inflation, deflation. So while staying. It gets a little bit bigger. Okay. Once again, angio. 잠깐만. 자, because of you. A deeper position.
형광 씨 삼성서울병원 들리시나요? 형광 씨?
Wire centralized.
형광 씨 삼성서울병원 들리십니까? 형광 씨.
네, 서울대병원입니다. 지금 여기 서울대병원이에요, 저기.
아, 그래. 오케이, 자, 라이브 다 됐다고. 자, 씬의 준비. 오케이, 씬.
형광 씨
No
삼성서울
regurgitation.
들려요?
Okay. Then we are going to switch to PCI in the next
혹시
when you
삼성서울
visit.
들려요?
Okay. YST.
삼성서울 들리십니까? 삼성서울.
픽테일 해가지고 프레셔 매주하고.
삼성서울 들리십니까? 삼성서울. 삼성서울 들리세요? 삼성서울. 삼성서울이요?
Any other comment from the panelist? The
네, 삼성 들립니다. 말씀하세요.
아, 네, 알겠습니다.
넘어간다네 안 넘어가네.
확인차
Question
전화드렸습니다.
to Dr. Hyo-Soo Kim. When the final deployment, you use the high pacing in this patient, but acute neo2 usually do not need high pacing, rapid pacing. Is there any reason?
It depends on the case. For this case, the position was a little bit high because I'm concerned about the movement, upward movement during final deployment. That's the reason why I did rapid pacing to stabilize the position of the heart.
Okay.
I totally agree with Professor Kim. I'm not sure whether you need 180 or 160, but definitely
네,
you got to have only one case with a small VPB that pops up the valve just when you deploy it, and you will do rapid pacing in any case. So it doesn't have to be 180, but definitely some kind of rapid pacing. But I want to say something else, Dr. Kim. Before you took all the device out, you were pretty sure that the valve is fully deployed. And I suggest in any case, again, from at least my experience, before taking it out, I'm looking at orthogonal view to see that it is completely fully deployed, because it happened to me that the nose cone was stuck because I could not see that on the RAO, it's not fully deployed, and it took the valve up. So this should be just a routine, but I think that's a wonderful, perfect procedure. Thank you.
Good point. Thank you very much.
Hemodynamics is excellent.
Pressure profile. Can you see the pressure profile? The pressure difference between the dichroic notch and end-systolic pressure is very low, very narrow. That means very good aortic index, new index. 138, 70, 50, 24. AR index, new AR index is about 5.7, no regurgitation. T, please. Final T. T로 바꿔줘요, 화면을. Okay.
Okay, this is the chamber longest view and...
We cannot hear it. Okay. Keep going.
Okay. There was a trivial parabolic leakage at the trivial top was after the balloon.
No leakage.
Yes, no leakage. Currently no leakage.
Cross section. Central leakage.
Yeah.
Why? I retrieved the pigtail already. Pigtail is removed here. Okay.
Actually,
there is
before the balloon dilation, the
보여줘봐.
TE finding there is some paravalvular leakage, but after the post balloon, the paravalvular leakage disappeared. Actually, your case is very educational.
저장을 보여준 거야?
Kim,
정말 멍청하네.
Kim, is a very nice cases and educational, and the new
Wait a
technique
minute. Dr.
using
Hwang
the
Do-yeon
accurate neo.
did not present the real T. 참, 황도현 멍청하네.
Okay, would you finalize your comment? We will move to the Samsung
Okay,
Medical Center.
please see the final T.
삼성서울병원 준비해 주세요.
You can see three cursor,
지금
yellow,
서울대병원입니다.
color.
Okay.
A little bit different level.
Short
Anyway, no regurgitation. Thus,
paravalvular leakages
when you
disappear.
experience acroneo, it performs better than you expected. That's the reason why I perform 2 TAVI live keys using acroneo this year. Okay, thank you very much. Yes,
Okay.
I
Show us
already
your
performed
final
left
result.
main stenting and RC stenting. This is RC IVUS image. IVUS, okay, after RC stenting, we deployed Onyx 3.5 by 38 with highest pressure for 20 seconds. MLD is 4 by 3.75, well opposed, fully dilated, more than 4.
Okay, the result is looks the excellent. We would like to know what type of the guiding catheter to fix the right coronary artery and the left coronary artery in your patient.
Here is or okay. And playback. 자, 아까로 돌아가 볼까, 영민? I will show you the intervention, left main LAD intervention, using a Judkin 5 plus we can see there is a kind of nodular atheroma on the left main and segmental stenosis in distal left main until the proximal LAD plus.
Is that the Judkin 3, 5, or 4?
Judkin 5 plus
5.
AP caudal view. You can see once again nodular atheroma on left main plus circ is okay. Stereo cranial view, we can see more clearly the left main lesion. So I planned stenting from the left main ostium to the proximal LAD, that we see the kind of normal-looking segment plus. Then I performed the pre-ballooning 3 by 15 plus several times. And then this is NG after ballooning plus. I deployed create 3.5 by 40 until left main ostium to proximal LAD plus. Here we can see the this view is best to securely cover the left main ostium plus. Distal edge located in the normal-looking proximal LAD segment. This is create 3.5 by 40 from left main ostium to proximal LAD. How up do we increase the pressure? 22 for 40 seconds? 40 seconds. Then this is really highest pressure and the longest inflation time, plus there's no indentation. Ordinarily, I stop the procedure here, plus, and I perform a part, left main ostium, plus, then angio. Still, there is a mild indentation of left main body that is located at nodular atheroma. Thus, I performed NC ballooning using AccuForce plus. Here, nodular indentation of left main, previous site of atheroma, plus AccuForce 3.5 by 8, 10? 8. 3.5 by 8. The reason why I chose AccuForce is it provides the highest RBP, 22 atmosphere, compared with 20 in Euphora. Euphora is 18. Emerge and NC track provides 20 atmosphere, but AccuForce from Terumo provides RBP up to 22 atmosphere. As I raise the pressure until 22, 23, 24?
I think 22.
Okay, plus several times. Then looks better, plus. Then we perform, plus I was recording after sequential NC ballooning. Left main LAD 아이버스인가 이게? Okay. 카메라? Okay. So the IVUS that you see is LAD, left main IVUS. Overall, it's widely inflated. MSA reaches about more than 10. The narrowest segment of MSA is 8.4.
Yes.
8.4 square millimeters. Then I coated coronary artery with heparin, 300 unit. I believe it is very important to finish the complex PCI by intracoronary infusion of small dose of heparin to coat vessels. That maintains about 24 or 30 hours because heparin is very sticky material to adhere the extracellular matrix because it is similar to heparan sulfate, component of ECM. Thus, our practice is we always finish complex PCI by IC infusion of small dose heparin, called as heparin coating. Plus, then I performed RCA using JR4.
These are easily accessed when you use a guiding catheter, right?
Not easily, but not
easily.
difficult.
It's the same
Not
to the cases to the Samsung Medical Center. That is the point in this live demonstration. How difficult it is, or is very easily, is nothing different?
It took less than 1 minute. It took less than 1 minute. As mentioned before by Dr. Guan, we have to meet such kind of case, coronary access in patients who underwent TAVI. Thus, it is very important to select valve type considering future coronary accessibility or to consider how to optimize commissural alignment. We already aligned the commissure perfectly, thus it is not difficult to access coronary. Plus,
did you have any difficulty to deliver the balloon or stent in the PCI procedure?
In this case, no.
The reason why
Because I was able to
why actually after the deploy of accurate neo, the upper crown is located in the sinus. Maybe the obstacle to advance of some device. That is the reason. How easy?
Usually, our intentional level of deployment is upper crown is just compressed, calcified the leaflet. Thus, usually the upper crown is just below the coronary ostium. The more important problem is this valve is also supraannular design. This neo-annulus is high than intravalvular device. That is a little bit important factor to feel the difficulty, not easy to do a coronary access, but crown is not a problem. Plus, backup is good because we can
we have 3 minutes, please.
Long stents. As you can see, this is Onyx 3.5 by 38. Previously, Create 3.5 by 40. Thus, the backup force is very good and cannulation is perfect. Plus, then I performed plus inflation up to 22.
No, 18, I think.
18 highest pressure?
Yes.
21. Highest pressure 21 for 20 seconds. Because I feel the highest pressure 21 may well oppose the stent strut to vessel wall. No NC ballooning plus because I see the no indentation. The lesion was not hard. Then we performed IVUS. As you can see, the IVUS finding, well position, MLD is about up to 4 millimeters by 3.5 millimeters.
Okay, we have 1 minute left. Please finalize and your comment.
Yeah, Dr. Kwon and I intentionally performed the post-TAVI PCI, but this is a kind of a demonstration. Because we have to consider future coronary accessibility and choose the valve. Dr. Kwon chose 23 millimeter Sapien. Orifice area is very small. There is higher chance of valve thrombosis. I don't agree. Implantation of Sapien 23. Instead of Sapien 23, accurate Neo 25 is really better in terms of coronary accessibility, no difference. In terms of effective orifice area, less tendency of valve thrombosis. So Dr. Kwon should choose accurate Neo in his case, like me, but he is not accustomed to accurate Neo implantation. That's the reason why we have to learn how to implant accurate Neo easily, more confidently by missional alignment.
Okay, your cases and Dr. Kwon's cases are very excellent and educational and informative. We real situation on the live. We really learn the new message and that enjoyed your cases. Okay, very good job. And
Okay, see you
I'd like
later
to-
with complex PCI.
Okay. I'd like to close this session. Before that, we fully enjoyed the coronary cases in the structural theater. Thank you.